So first up, we've got our pediatric problems. We're gonna start with our little guys and talk about those. So first up, encoparesis is typically, so when you think of toilet training or potty training, first thing, just like when we had Miss Martin for growth and development, you have to throw out the kids you know, nieces, nephews, your own kids. So let's go by textbook. But when you think about potty training, when is the most appropriate age to start training? Does not mean they have to have mastered it, but to start. Two is where we're gonna start. And then, so what would be an age that they should kind of have it down by now?
11.
7.
Let's hope.
5.
Let's hope. I like 4 or 5, so like pre-K age, would be that, we'll give them, so I would hope that they're potty trained by 3, like just for developmental sake, but textbook will give them to age 5 for urine and 4 for stool. They think that poop is easier to master than urine, and so the book says. But here is where things can get complicated, and we'll talk more about the etiology, is that for enuresis, that's gonna be your bedwetting. Encoparesis is that they're incontinent because they either hold their stool until their sphincters just release on them, or it is just they have no clue of body signal. So it kind of is an umbrella term. Most common in boys than girls. Children can grow out of it. They don't necessarily need medical intervention or medication, just with some training. And then we need to consider treatment if bedwetting occurs after 5. But we won't give medicines because of the side effects that we'll talk about when we get there until the age of 7. But one of the most common reasons is that we start potty training too early. And so all of the things that you're telling them, they're not picking up on those biosignals, and it just confuses them, and so therefore potty training's not really super successful. If they developmentally are understanding and mastering it, that's fine. But if you're having those peaks and flow, or ebbs and flows in, they're trained, they're not trained, they're trained, they're not trained, they may not be developmentally ready for potty training, so wait till the age of 2, because technically you can start around 18 months. But age of 2, if they're not getting a hang of it, just wait, give them some time. Be in Bruce a little longer and wait till 2. So there we go. Another common thing with, well, we'll get there. I'm ahead of myself. So common things that contribute is if they are constipated. So what would they be missing from their diet if they're constipated? Fiber and fruit, for sure. Kids usually should not be constipated. If they are constipated, it is because they're junk food junkies most of the time. As long as you're getting them their, how much fluid should a child have a day? Because what's your normal, so cut it in half for their size. It's very quiet. What?
1.5.
Okay, so that's your midpoint. So Chuck's putting it nice in the middle. So it is 1 to 2 liters a day for a pediatric patient. For adults, it's the 2 to 3 liters a day, right? So 1 to 2 should be their minimum, what we're going for. What's another common thing that children have as a lot as infants and babies that is constipating? I heard it, say it loud. Milk, absolutely. Specifically animal milk, like human milk, if they're breastfeeding, usually does not have the same result because it's more water-based, or it's exactly what the humans need. Where if we're using animal milk, especially whole milk, it has a lot of calcium, and we know that calcium can constipate. All right, family history of diabetes. That's usually for the enuresis, so like if the child is also likely to have type 1 diabetes congenitally, that would set the stage because obviously the polyuria factor, and so they're unable to control the amount and volume of urine that they're going to have if they are diabetic. So that would be an indicator to maybe assess your patient for diabetes if you work in the baby world. Chronic UTIs, because we know that UTIs cause scarring and damage to the tissues and organs, and so that would not promote proper function. If they have urethral valves, which is another exemplar we're going to talk about hypospadias specifically, but there are other spadial diseases where the urethral opening is not in the head or glands of the penis like we expect it to be. It's either on the base or on top, on the mid shaft, things like that, but we'll look at that later. And then problems in the spinal cord, so that would be one of those neurogenic problems that creates difficulty for us. So some things that we can do to be helpful of enuresis is limit fluids before bedtime, because that would help them to not be full at night, and maybe not have the maturity response to wake up there, because that's pretty mature to feel that at night. Caffeine, so colas and teas, if your kids are having those. We would want to use bathroom regular intervals throughout the day so that we promote just going so we can go again before bedtime so they go to bed empty. Calm routine. One of the best things is to get them to have a good night's sleep, so limiting tablet time, blue light. You can revisit all those sleep hygiene habits from 112, but good practices. We can get fancy and add these alarm systems, so very much like you have the pressure alarms that we put in the chairs for your fall rest patients, there are also wet alarms that will pick up on the warm liquid on there and will make a noise that should alert them to wake up and hopefully go finish using the bathroom. They should be a part of changing out the sheets, and it should not be, we're going to talk about some discipline and behavior models in a second. But it shouldn't be a shameful thing or a bad experience, because that may cause additional stress and make the behavior continue. So we're going to keep our calm, but they're going to help clean the bed. We're going to go get sheets. They're going to take them as much as they're able to do for their age that they are. Be a part of that, so that hopefully they won't, because why would you want them to be involved? I'll let you answer that. Why would you want them to be involved? Huh?
They're independent.
Well, independence, but what else?
They have to do if they went to bed.
So if, hopefully it'll help limit the behavior if they're having to do all of this, and I don't wanna do that anymore. I'm gonna try to figure out what this feeling is and get it. So, and then there's another one, so it's create a reward system. We praise dry night, so every night that they go dry, there's a reward of some sort, and that's just based on what your kid makes them light up. That's gonna be different. And then bladder training. You're gonna try to have them, if they can perform Kegel exercises or they're mature enough to understand that, you can have them try to do that. You can also try giving them, maybe this week we'll go to the bathroom every hour, or try to go to the bathroom. Then the next week we'll go to the bathroom every 2 hours, and so they can get used to holding it overnight. Very much like training a puppy. So some things you may see for treatment if this prolongs is the alarm therapy. That's the most common. Desmopressin, we said that would start around age what?
7.
About 7's when we start medicines. Really quick, pull up on U Central. Let's see what some of those side effects are. And it will help you figure out pediatric wise what you may not want. And what is desmopressin? It's a what? Antidiuretic. And let's look at for indications there. Some patients who can get it. What's it saying that's used for? How about that? Some weird stuff. Then you've got this von Willebrand's and all that. But most commonly, that's going to be for your nocturia. What it does is it helps to dry everything up. And so they'll hold the fluid. You give it to them at bedtime, and they would hold that fluid at night. And then when they wake up in the morning, they would be full and go to the restroom. All right, side effect wise, what jumps out at you?
Seizures.
Don't like that one.
Hypernatremia.
That's your danger one. But anything, they don't have it on here. Boo.
Anaphylaxis, water intoxication, hypertension. Oh, hypertension.
Okay. It's not in, I was going through the rest of you, so it's not in there. So in a nutshell, the easy version of what desmopressin does before the age of 7, think about where's the antidiuretic hormone, where have you seen that produced?
It's
Pituitary from RAS, remember that? So, and it's causing, for urinary, like water retention and all of that. So think about in a young kid who's mostly water, and then I'm making them hold even more water, it's likely for them to go into what they call water intoxication, and which it's in hyponatremia is how Davis drug guide has it. But the biggest damage is that we can cause some brain problems while they're developing from the excessive amounts of water that drug would make them hold. So about age 7, their kidneys are mature enough to handle the medication and get it off of them in the morning, where before that they still may have immature kidneys.
So you said it's the pituitary gland and it could cause problems with that. Could that cause like prolactinoma, like a mass on the pituitary gland?
Oh, that's fancy. Won't you research that one? That's fancy. Not prepared for that one. I'll be the first to say I'm not the neuro.
Okay.
But we can look into that, so make me a note and we'll look at one of the breaks, we'll dig into that, because that's, but it would make sense to me, because if you're changing a developing brain gland, that it could cause some cancer
And
rates.
prolactinomas are typically developed, before, I lost the word for it, before you develop, you know,
And since it is developed, it makes sense to me,
yeah.
but I don't have any science to prove that, so we're gonna look. So make me a note.
Does it help control bleeding and hemophilia?
Because the water retention is that pressure, so it puts pressure out on the,
Okay.
where they would pop a bleeder.
That makes sense.
Talk about the reward system. Here's your behavior chart, for example. So whatever their little praise is, that if we have like 5 draw nights, we go get a Happy Meal, or we do whatever their favorite thing is. We go to Surge in the jump park, or whatever their thing is. And so, obviously smaller goals for smaller frequency and larger goals for larger frequency. And then in severe cases, that if they have not mastered it with everything that we've tried in office, they may have to get some psychosocial services involved and go to behavioral therapy and see, is there another cause? Like, is there a childhood trauma? Is there abuse? Is there something else, like just not normal? That's gonna help out there. Okay. Trying to think. Make sure. Nope, the biggest thing that your book has is reducing shame, so it shouldn't be a shameful or punishment. We reward dry bed. Make sure that the child is age appropriate. Try to pick up on their signals and cues if you can. So if you see that your kid's standing cross-legged or doing the potty dance, hey, I see that you're trying to cross your legs or holding the area, let's go use the bathroom, things like that. Super simple. And being honest, we had a kid in our family who had encoparesis, the poop one, holding their stool, literally because when they finally got to talking to him, he didn't want to have to, because he knew that going to the bathroom was like an inconvenience, because you had to get undressed, you had to use the toilet, and they wanted to stay out on the playground and play. That was literally the reason when we started talking to him. They were scared that he wasn't going to get to have playtime, and so if he needed to go to the bathroom, he was going to have playtime, he could just go later. And so after talking about that, figured it out. So when they extended his playtime, so it's like, if you need to go to the bathroom, we'll go ahead and go to the bathroom, we'll extend your playtime, so that because he was scared he was going to miss like recess going outside. A little reason. So kind of interesting why people do what they do. Questions about those two? Not a whole lot, just some people who might be at risk to have those and why. And then what are some treatment options that we can do to help them master that. Very easy, very straightforward, not gonna be hard questions about it. Then this one, benign prostatic hyperplasia, aka BPH. You see in your picture here that your prostate, actually, if we had a 360 picture, actually encircles all the way around the urethra, and then has those Cowper's glands. So what's your prostate for? What's this job? What's it even do?
Ejaculation.
Yep, it just makes those, it has those little Cowper glands that puts secretions in there for that. And then over time, then, thankfully, if we all live to be old enough, we have this to look forward to. It is typically non-cancerous. It doesn't mean that the cells get larger, it just replicates and there's more of them, so the tissue just gets larger. And so due to the increased size, chokes off the urethra, which causes all of those problems, be it UTIs, which is your most common and classically how BPH is found, but they're gonna have those, what's their primary complaint gonna be? I can't pee, or small urinary stream, weak urinary stream, or where I used to just pee, now I have to I dribble for forever, something like that. So change in their urinary habit is usually your first indicator, if not accompanied with some sort of UTI, burning discomfort from that urinary retention, because they cannot empty their bladder entirely because of that choked pressure on the neck there. So it's non-malignant, non-cancerous enlargement of your prostate, very common in aging men. It's typically gonna start for us around the age of 55 is about where that becomes a risk factor, but 55 and up, anything is possible though. And then it is the most common form of cancer in men, and so we'll talk about some ways that we can monitor for that. Moving on, so what happens is these nodules, which is the increase in the number of cells. So it's different than in cardiomegaly, for example, where the cells of the heart get larger. The cells are not getting larger, there's just overgrowth of those cells, which makes it appear larger. And it is not formed from hypertrophy, okay? Not the increase in size of those cells. So they're not getting larger, it's just more cells. And then this occurs over a long period of time, and typically it's just, I'm sorry to say, if you don't use it, you lose it. So those who do not maintain sexual health later in life, it just kind of encourages the hyperplasia to take off. So it's increased by or influenced by androgen, so those testosterones. So more exposure to testosterone. So people who either take illegal testosterone, the roids, or if they just naturally have high levels, that increases the growth of that tissue. Aging prostate is more sensitive to available DHT. I will not ask you for what that stands for, but that also is what is the culprit for alopecia or male pattern balding, is DHT. So it's a byproduct of when your body uses testosterone. It produces this DHT, which promotes the growth of prostate and for male pattern balding. So if you have a bald male, hint, hint, Dr. Fuller, will be very prone for BPH when I get older. Strong family history, dad, and just about every guy on our side, so that'd be an indicator. And then an increase in estrogen levels, says may contribute, and that would make sense too for your elderly male, because we do not produce as much testosterone at that point. So do you see why I say if you live to be long enough, we're gonna have it, because at some point you're gonna have all these things. Rare before the age of 40, typically 55, but 60s we're gonna start having those symptoms. And then 90% of us are gonna have it by our 70s, and 80s we got it, it's yours. Most common is gonna be your African Americans or Hispanics, as far as earlier development. And then Asian men develop symptoms later than Caucasian. So that would be your last line, but African American, Hispanic, your most occurring. And then of course presidents of, if they were a eunuch, then they would not be susceptible because they were never exposed to testosterone, because that is your greatest risk factor, is that long exposure. And so thinking about your premature developing children, so those that have secondary sex characteristics before the age of 12 or 13 generally, they would be more prone to having BPH in the 40s because of that early introduction of testosterone. And And then removal of testes after puberty, if you wanted to, for developmental sake. Get the sex changes and then take them away to prevent prostate cancer, you certainly could. Clinical manifestations, we talked about, they're gonna have that decreased urinary flow, urgency, they're gonna need to go pee all the time, dribbling, incontinence, some bladder pain from the fullness of the bladder. Those are the big ones we pulled out of there. In our worst case scenario is because it's higher up than the low, you're gonna get more of the kidney involvement, so hydroureter and hydronephrosis, because the the collection point's higher up than from the end game. So working with other members of the care team, you're gonna try to diagnose it, prevent complications. So we're gonna try to, what are some things you think we can do to promote bladder emptying? We taught it about ladies sometimes after pregnancy. This was in 112. It was, what, does anybody remember from the Kahoot what that other maneuver was? It wasn't the Kegel, but it was another maneuver. Who? That's bearing down for bowel movement. Called the Creed maneuver, C-R-E-D-E, Creed maneuver. And that's essentially where you're gonna take your fist and put it over your suprapubic area and press in to try to put some additional pressure to help empty that bladder out, maybe one. We can also introduce some medications. What's a very popular one you give all the time? It's a little capsule, huh?
I was gonna say Prednisone.
It's related to that one. It's another Zosyn, and not the antibiotic, but Tamsulosin. You all heard of that one? Flomax, Tamsulosin. Very common medication to help that, but Perzocin, the Cardura, that's a good one for it too. Notice it's irreversible, so we're gonna have to work with it. So we might help them with fluids at bedtime, much like our enuresis patient. And then it may be stable or improve the symptoms if we can get some medications involved there, but not reversible. So, I don't know if it's on here, there we go, perfect. Digital rectal exam, you're typically not gonna get to perform your own digital rectal exam unless you're just super flexible, so have their doctors doing that during their wellness screening or annual screening. And so some keywords I would want you to look for is how do you think a prostate should feel? What would be a normal tissue feel?
Smooth.
Yes, and what else? How do you want your skin? Huh?
Squishy?
Or soft, or, you know, I like squishy, okay, so it's not like hard or anything. So words you would not want would be like hard, lumpy, bumpy, nodular, firm. So things that would indicate hard or abnormal tissue growth, so the bumpy, lumpy, they'll call it boggy. That means, like, instead of being your word squishy, instead of being squishy, when I mash on it, it doesn't really give. It doesn't go anywhere. Boggy is just very firm. So that would be some words, if you read in your doctor's report, that would indicate that we're having some prostate issues. Urine flow rate test, exactly what it sounds like. You watch them pee. Do we have a good strong stream that does not stop from start to finish? Or if we have starts and stops, or it's weaker and stronger, like there's some, there's a difference in quality while they're urinating. It's literally that simple. You watch them pee and rate the quality of their urine stream. Post-void residual. This is going to be where your patient uses the bathroom, then we use a bladder scanner or a CT, other ultrasound device, whatever you have on hand, and we see how much urine is left behind in the bladder. What would be a significant number, you think?
250.
I love it. 250, 500, you'll see different resources. But yes, anything greater than 100, we're holding on for some kind of reason. Pressure flow study, this is the one I would not want to sign up for. It is gonna be where we measure their urine flow quality, but guess what? You have a ureteroscope in there while they're trying to do it, and you're measuring it with the pressure around it. I could not imagine trying to pee with something in there, but that's what a pressure flow study is, and it actually gives you pressures, and I will not quiz you on that, but that's what that test is if you see it. Urinalysis, urine culture, we would expect those. We're checking for UTIs. PSA, prostate-specific antigen test. This is your BPH marker and your cancer marker. If it's elevated, then they likely have BPH. If it's over normal value, then they are highly likely for prostate cancer. So your range is actually, if they fall in that range, they have BPH. But if they're over the normal acceptable range, then prostate cancer needs to be ruled out. Cystoscope, where they go through the urethra and visualize the structure of the bladder to see if it's a bladder structure problem. And then symptoms assessed with an international prostate symptom score. Again, I will not quiz you on that tool, but if you see that tool or hear about that tool, if you work on a urinary with a GU place, that is the tool, just like you use the Aldrete score for surgery and the Morse for falls. That's kind of your standard tool for assessing the severity of their BPH. Because lab value is subjective depending on your patient. So, then for surgeries, we have all types of ways that we could tackle here. The most common is gonna be your TURP. So if you wanna star that one, highlight that one, whatever, that's kind of your classic gold standard go-to. But I will tell you about the other ones that are out there, just in case you're exposed to that. Transurethral microwave sounds exactly like what it is. You're gonna try to blast it with microwave, aka heat, and try to shrink the tissue or burn the tissue away, so that it puts less pressure or stricture on the urethra. Tuna, we're gonna do a needle ablation. You go in with a needle, so you can imagine that's gonna be a suprapubic stab that will go in and actually try to ablate or grab portions of that prostate. So you can imagine the trauma and the risk for hitting other structures is why that's not preferred, but could do that. Transurethral surgery, they will actually go in and do what they call shave, or shavings. They'll kind of clip away, shave away the overgrowth of the tissue, and try to resection it. And then a TUIP, intracanthal, let's see. I'm so good with abbreviations, but instead of using a resection, they just remove large portions of the prostate. But let me get you what that stands for. Transurethral incision of the prostate. So that's the entire, removal of what all I can get. And so, obviously, if they are still sexually active, that would not be your preferred, because that would get rid of your secretions. Then, of course, we could do an open surgery, just general surgery, slice them open, take it out that way, or laser treat the area. But again, we don't like the needles and lasers because there's a lot of other structures in that small area the prostate takes up that we could hit other things and cause other problems. So that's why your TURP is classically what you'll see. Newer treatments, they can go in there with this balloon-like device, very much like your balloon pumps for cardiac stuff, and actually inflate or stent the area to try to expand on there. But what do you know about balloons? Has anybody ever seen anybody have a balloon of like the esophagus where they go and do an esophageal stretching or ureteral? How do those work? How long does that last you? Your shoes are in your head, not long. Yep, it don't last.
No.
So it's a temporary fix, but it's non-invasive. They don't have to have all the continuous bladder irrigation and all the things we're going to talk about in a second.
Is that the same thing when they balloon the accesses for visuals?
They're trying to stretch them out, and it's very temporary, but it does stretch the tissue out, gets you some expansion there for a little while. But those are temporary, so that's, again, why they're not as often, because they're not going to last. TERP is usually pretty good until the tissue regenerates, which they'll just have another TERP and it'll be fine. Stephanie?
How long is temporary?
Temporary, 6 months to a year tops.
It's not very long.
In my experience, no, it's not, I mean, but, hey, it's inpatient, outpatient procedure, just go, balloon, go home, I'm not gonna bleed, I'm not gonna have all that stuff, it's just, so, for convenience sake, it's great, but, not a long-term fix, it just depends on your time. So, TERP, yes, sir,
I had a Urolift before.
you're,
Yeah, juice ain't worth the squeeze on that.
it's, I mean, but there,
Lasts about a year.
it's convenient though, recovery-wise, there's not a whole lot of,
It was
but,
a little painful.
but compared to
A turtle.
this one,
Yeah.
woo!
And the dysfunction, there's some sexual dysfunction on the turtle, I believe.
Yep. Always does when it gets cut on, so that's why we try meds and other things first, and then, surgery should always be your last ditch effort, like there's not really anything else quality wise. But all the parts and pieces. So, with this particular model, you only have one irrigation bag, but I would always encourage you to have two, because inevitably when one gets empty, you don't want to be scrambling to try to spike another one. So try to use the 2-bag system if your facility has both, but if you only have one, just use what you have. But just like all your other IV stuff normally, but the focal point's gonna be your 3-way here. You're gonna have an irrigation port, a drainage port, and then your balloon inflation where you stick your syringe to do that. Your urinary drainage bag, if you use the standard kit, which most of them are, you're gonna just insert a standard Foley, and then use those parts and pieces. I would encourage you to build your Foley kit. So learn what's in your Foley kits where you work and build yourself, because obviously you're not gonna use the standard 16 French Foley, because we talked about 3-way Foleys are typically what size comparatively? Larger, because they're gonna have clots or little sediments that are gonna go through there, and so they would be likely to clot using a standard size. So you're gonna use a large Foley, and then think about your drainage bag. You've got them connected to 2 3-liter bags up top, so is that little 1,000 drainage bag gonna do you? It's not gonna be worth anything. So just build your kit. So grab your own Foley, grab your jelly, just build a kit. Take the extra stuff and do that. French-wise, what would be a good starting point for a 3-way? So 16, we said, was kind of like our 20 gauge for an IV. 16 French is kind of your starting for a Foley. But what about if it's gonna have CBI? 22. Let me garden hose. 22, 24, 26. So if you, depending on that's why we're like, go visualize your anatomy. So if you have some innies instead of outies, you're gonna need the smaller, but 22 is kind of that start point. Because any smaller than that, it's not that, 16 would work and seal off and be just fine, but, so also thinking about that, because it's a larger size catheter, what's gonna happen to the structures because of the pressure of that large catheter? They will actually tear. So they will call like the glands can actually split, and it's usually along the coronal nerve on the base of the penis. From that increased pressure and chronic pressure, you can actually have urethral splits. And so then those would have to be addressed when the 3-way is stopped and things like that. So use the smallest catheter that you can that's not gonna clot off. So time and experience will tell you there, but just giving you things to watch for. Obviously, the increased catheter size, they're gonna complain of pressure and burning, should go away. Remember the trick that we said, if the Foley burn does not go away, then the catheter size is too large, you're gonna have to go down a size. But if you go down, know that your likelihood for clots goes up, so keep your fluids higher on the smaller catheters for a little longer period of time. You're gonna have a little roller clamp, which is way up high. I like it down here around where you can see your drips, but it's gonna control your drips. So after surgery, after the TERP, how do you think the fluids are gonna be? Wide open, because we don't want anything to clot there. And your initial color is gonna be what? I'm gonna ruin your favorite beverages today, but we're gonna talk about that. We're gonna call it fruit punch, is where you're gonna start. So a fresh after surgery is gonna be that bright red, we would expect that. And then as the color in the tubing, you can't go by the bag, cause think about, you can put one little drop of red in there, it's gonna, so watch it, what it's doing in the tube, not collectively in the bag. So if it looks like fruit punch in the tube, then we need to keep the fluids running, cause obviously they're not coagulating. But as it starts coming down to pink lemonade would be the next shade that you'll commonly hear, even though that's not textbook, but you see light pink or pink lemonade, then we can start decreasing the amount of fluids. You wanna go gradually and make sure they maintain there, and if they do, we can start easing those fluids down. They're starting to clot, and I don't wanna wash or put extra pressure on those clots, so it'll stay. Then after pink lemonade, it's gonna be kind of like this big, just blood tinged. So it's just got that touch of red, and you can slow it on down, and as we get back to yellow, then we're good. We can consider stopping the irrigation. So again, a good nurse trick, you had an order to discontinue something, or you all won't, I encourage you, don't go in there and just yank your catheter, don't go in there and just, same thing for irrigation. Stop your irrigation, because I can detach my irrigation, I can pull that little slip tip out, and I can put a stop in. They'll have a, what they call a port stop, cause it'll actually plug a hole in there, and we would tape it, of course, for reinforcement, cause patients are gonna move, and then we're gonna get pee everywhere. But we would plug it with a little port stop, and you would make sure that they maintain, because wouldn't it stink if you pulled the CVI and then they clot off and you need to put it back. So that's one of your helpful tricks there. So we're gonna put a port stop in and make sure that we are maintaining that clear yellow urine. Also, thinking about two schools of thought. Going with your intakes and outputs, because obviously they would be on strict eyes and O's, because if we're giving them 3 liters, every couple of hours, we want to make sure that comes back and doesn't pop their bladder. So you would like, some facilities will have you, they like you to keep up with every bag that goes in. So you would keep up with every 3 liter bag that goes in and every 3 liter bag that comes out. Some facilities say just disregard it since it's irrigation, just take the 3,000 off of the urine that you're collecting. So it just depends on your facility. So we will tell you if there is an intake and output question, if we want you to include irrigation in your eyes, nose, or disregard irrigation in your eyes, nose, just what they have in, what comes out. But we'll tell you what to do with your irrigation, to either include it or just don't put it in, you're in or out. So, questions about TERP, CBI, all that. What you're never gonna do with your irrigation bag is never let it run dry, because you will have a clot. We're gonna say you do have a clot, or you think you have a clot because you've watched maybe 1,500 milliliters go in and you only have 600 down in the drainage bag. Where is it? It's starting to hold in their bladder. So we're gonna talk about manual irrigation really quick. So if you have a patient with CBI, go ahead and just have it in your room as a part of your care. Don't wait until they have a clot before you get it. You're gonna have some sterile saline ready to go, a big bottle of it. And then you're also gonna have your 60 milliliter piston syringe, very much like what you did for NG tube or PEG tube feedings, things like that. So you would detach the drainage bag and then, clamp your irrigation, and you're going to put your 60 ml syringe there where it's the drainage bag, and you're gonna pump that 60 milliliters of saline in and out, in and out. You're gonna see all kinds of good gunk and clots and come into there. And then if you get a lot, take the clots and drain those out, get you a fresh 60, and do it again until you don't see any more clots. And then, but here's the problem. So when you have to do manual irrigation, what's happening internally? Think about, where'd you go? Increased pressure. So, and then you took out all your scabs or clots that you did have because your clot kind of fell off in there. So essentially you're restarting. You're back to fruit punch, pink lemonade, blood tint. So you start up. So we don't like manual irrigation because we removed any progress we had. So that's why it's better for you to slowly decrease your irrigation speed. I'd rather keep the speed up longer than I need to than to get over anxious, they clot off, and then, cause we'll just start all the way over if you have to manually irrigate. Okay, kinda got a grasp of how that goes. This would be the big one for BPH, is the TERT procedure and maintenance of that, cause a lot can go wrong quick for new nurses. So NCLEX and HESI love to ask about TERT and continuous bladder irrigation, because it is one of those that your patient can have harm. They can have a bladder rupture, they can clot off, and they have to go back to surgery. There's just a lot of, and you figured out by now, HESI loves to ask you things that are gonna actually result in patient harm. So this would be your big one for BPH. And then I've already talked about our go-to medicine. There are some other ones on here, or on your prep work rather. But there's two classes of medicines that we can do. If it gets into the cancerous scare, that they're having pretty severe, we'll give them the anti-androgen, so that's gonna be your testosterone blockers. And so obviously they come with all the sexual health side effects that we don't want. It is not your first line. However, your other side, the smooth muscle relaxers in the alpha adrenergic class, or AD5, as you'll see it in your Dave Stroke guide. We like that because it's gonna relieve the muscle stricture and relax everything and help with their flow. So that one's your tamsulosin or the prazosin. Those osins will be your smooth muscles, the AD5s. And the reason we like them is because the only side effect that really bothers them is the orthostatic hypotension. So when they first start the medicine, you want to see what their blood pressure does first. So change positions slowly. Don't drive heavy equipment and all after taking it until we know how you're going to tolerate it. But notice it says some of those medicines may worsen symptoms of BPH. So if they are taking other medicines, see if some of the side effects are testosterone boosters, where it would put them or prolong them to testosterone, or would increase estrogen production, which would worsen that too. So look at medications as root cause. So for example, some medicines that would not be helpful to if they have BPH is pseudoephedrine. What's that? Sudafed, that decongestant. So those actually counteract your alpha adrenergic agents. So looking at that. Antihistamines would not help because they're going to dry them up, which would make it harder to avoid or eliminate. And then testosterone, because we talked about the testosterone exposure increases BPH. Non-pharmacological things you can do, obviously avoid things that make you pee or give you the strong urge to pee, like alcohol and caffeine. Wouldn't want to drink a lot at night. Try to spread the fluids out rather than having gallons at a time, so there's not this great buildup. And then some of your same things that we taught our kids to do to help with overnight wetting. There you go. Okay. Take you a moment's break.
A month?